We were discussing FFA and ICGA. So इसमें यही था कि angiography has its different stages, right? In the first stage, when the dye is newly injected, it's first visible inside the arteries, then inside the capillaries, then inside the veins. Now, why we use ICGA specifically? Because ICGA, fluorescent fundus angiography, it does not stay as long inside the chorea. Yes, as long as it stays inside the retina. यानी कि FFA, fluorescein, it stays equal amounts of time or less amount of time in the choriocapillaris compared to the retina. So it is used to better visualize the retina. Indocyanine vein angiography, indocyanine vein dye. This dye sticks a while inside the chorea. So it is visible inside the choriocapillaris and all the important vessels over there. So in order to visualize those vessels better, indocyanine vein is used instead of fluorescein stain. Okay. So ICGA in our case, it will indicate leakage, exudate, edema, all that around the macula. The same findings which we saw in FFA. But if FFA is inconclusive, then ICGA is a better thing to do in cases you want to visualize the choriocapillaris. Any other investigation, or we have reached our diagnosis? क्या diagnosis है फिर हमारा?
Degeneration.
Choriocapillaris. As
ARM.
इतना उसने बड़ा लिखा हुआ था, that diagnosis is age-related macular degeneration. Age-related macular degeneration. Which type of age-related macular degeneration? Exudative. Exudative. Also called?
Wet.
Why is this wet ARMD and not dry ARMD?
Because of the hemorrhage.
Exactly, because of the hemorrhage. Because we saw characteristic findings of leakage and hyperfluorescence and exudation on FFA and ICG, indocyanine vein angiography. Now, just why do we need to perform these investigations? I've told you the rationale that ICGA is trying to better visualize the vessels, the choriocapillaris, the vessels of the middle layer of the eye. Yes. Why do we need to? Why? How does this relate to the pathology of retinitis pigmentosa?
इसमें membrane बनती है ना wet exudative में?
Membrane बनती है? क्या किसी already formed membrane में abnormality होती है?
Choroidal?
Yes, choroidal. What choroidal abnormality? What is the choroidal abnormality in age-related macular degeneration?
Neovascularization.
ठीक है, neovascularization. There can be neovascularization. So, anyone else? और कोई ज़हन में कुछ चीज़ आती हो? क्या मसला हो सकता है? So one said neovascularization. All right, choroidal vessels में neovascularization हो जाती है. और कोई issue आ सकता है वहाँ पे?
Age के साथ से लीकेज होती है. लीकेज होती है.
Age के साथ leakage with age. Leakage from choroidal capillaries with age. That is good. That is one of the main pathologies. और क्या हो सकता है? Aneurysms. Now, Aneurysms, we know that they are due to progressive weakening, and they specifically occur retinal aneurysms. They occur in diabetic retinopathy. Okay, microaneurysms is all that. In ICGA, and microaneurysms are not so much present even in the choroidal vessels. Okay, so they might relate to leakage of choroidal vessels. They might relate to leakage of vessels, but that is not the case here in this case. In our case, we have neovascularization, we have leakage from the choroidal vessels. But how does this choroidal pathology translate to retinal signs? कैसे होता है कि choroid में मसला आ रहा है तो रेटिना में चीजें हमें नजर आ रही हैं? We know that they are close together. We know that पीछे मसला है साथ ही आगे रेटिना पड़ा है उसमें इशू होगा. But there is one important link which we are missing at the bottom. Choroid में ये मसले हो रहे हैं. So is there usually any barrier or anything keeping choroid and the retina apart from each other?
Brush membrane.
This membrane is very important. Brooks membrane. Brooks membrane. Why is this membrane important? Why is Brooks membrane important?
एज के साथ डिजनरेट होती है.
Visual degrade. That is the pathology in this case, right? So a little bit about the anatomy over here. Brooks membrane, it separates the retinal pigment epithelium, which is a part of the retina, from the choroidal vessels, which are part of the choroid. This Brooks membrane, it normally functions to transport the retinal pigments, which have been metabolized, to the choroidal vessels. हमें पता है कि रेटिना की जो फोटोरिसेप्टर लेयर होती है, it receives its nutrition from the choroidal vessels. Nutrition and metabolites भी वहाँ पे ही discharge करती है. What are the metabolites? They are the end products of rhodopsins and scotopsins. Specifically, when we are talking about the cones of the fovea, they are the different scotopsins of the different three primary pigment colors जो हम perceive करते हैं. So these pigments, they are transported across the Brooks membrane to the choriocapillaris, the capillaries of the choroid, which from where they are transported elsewhere to the body. Similarly, the nutrition is received from this membrane. Now, this membrane has to dysfunction if there is to be any accumulation of pigment or fluid over here, right? And secondly, there must be another pathology. Either there must be a neovascularization, there can be neovascularization, we have fibril vessels which leak and can cause a subretinal hemorrhage, or there can be general leakage from the vessels, which and the fluid it leaks beneath the Brooks membrane. Okay? So this is the pathology or the pathophysiology of age-related macular degeneration. That there is some fundamental pathology with the vessels of the choroid. That can be leakage with age. That can be due to age, sclerosis of the vessels. Sclerosis means hardening of the vessels. Vessels, they usually harden with age, and this hardening can be augmented by hypertension. Okay, hypertension के बगैर भी vessels, they become tougher and less flexible with age. So either there's sclerosis with age or any other problem. This is the main thing. This, coupled with dysfunction of the Brooks membrane, causes leakage of fluid between the choroid and the Brooks membrane, and further seepage between the Brooks membrane and the retinal pigment epithelium. और यहाँ से फिर आगे fluid बढ़ता जाता है. So this is what we have to remember. And we do ICGA or indocyanine green angiography to look at these vessels. Because it is age-related macular degeneration. That's a good question. I don't have the answer to that. ठीक है, इसमें कहीं और फर्क नहीं पड़ता. It only affects the macula. Now, the important thing, why is the macula? इसमें एक important reason ये है कि we know that on the macula, only 3 layers I think are present. आपको इस बात का कॉन्सेप्ट है कि ऑन मैकुला द रेटिनल लेयर्स आर वेरी थिन, द कोन्स प्रेजेंट हैं, गैंग्लियन कोन्स प्रेजेंट हैं, उनकी immediate axons present हैं, and then the ganglion cells are present. So it's very, very thin. And the fovea and the macula, it receives all of its nutritional supply from the choroid. ऐसे ही है ना? ठीक है? It's relatively vascular. There are no retinal vessels over there. So there are no retinal vessels over there. It is very thin at that, and it receives all its nutrition from the choroid. So if there's anything wrong with the choroid at first, because the macula is receiving all of its nutrition from the choroid, it will be affected more. That is one of the reasons why it only occurs with the retina. If there's neovascularization and leakage of the vessels elsewhere, so yes, there will be a detachment. उसको choroidal detachment कहते हैं. और pigment epithelium detach हो रहा है RP from the Brooks membrane, then yes, उसको pigment epithelial detachment कहते हैं. That occurs in ARMD, and it occurs elsewhere as well if there are choroidal diseases, like we discussed last time. That can happen. But if there is no underlying disease or pathology, if it is only related to age, if we can see the characteristic signs and symptoms, characteristic signs on slit lamp examination, on FFA, on ICT, we find things on investigations which are confirming this pathophysiology, then this is age-related macular degeneration. तो हमने एक टाइप पढ़ी थी एक्सुडेटिव रेटिनल डिटैचमेंट की, ठीक है? We discussed two causes only. उसके what were those two causes?
Tumors.
Yes, number one was tumor.
Tumors or inflammatory.
Tumors and inflammation. Okay, tumors, and second is inflammation. These. अब what is retinal detachment? Definition क्या है retinal detachment की?
Separation of sensory epithelium from pigment epithelium.
Pigment epithelium, right? That is retinal detachment. Now, if I say the retinal pigment epithelium, it detaches from the Brooks membrane. उसको क्या कहेंगे?
Macular degeneration?
नहीं, इसको that is called pigment epithelial detachment. Well, that is a sign or a finding. That is not a choroidal detachment. Now, if the choroid, it detaches from the underlying sclera, or it detaches from completely the retina and the sclera, then that is called the choroidal detachment. ये बताने का मकसद ये है कि the detachments which we see on the OCT, they can be of different types. Now, those diseases of the retina जिसमें choroid involve हो, these include age-related macular degeneration, choroidal neovascularization, central serous choroidoretinopathy. ये सारे अजीब से diseases हैं. I don't like them very much. These can have different types of detachment, and the disease spectrum, यानी कि क्या-क्या हो सकता है इनमें, it's very difficult for us to understand at our levels. That is why we won't dive that much into them. We will only discuss the essentials. Okay? So different things can happen. Now, let's review this briefly. On to our next case then. Age-related macular degeneration of the wet type. It will present in an elderly woman, classically whose age is greater than 65 years of age. She will have no other predisposing factors. She might have hypertension. Okay, but if it is hypertensive retinopathy, she will have all the other signs. So an elderly woman who presents with rapid loss of vision unilaterally, and on examination, on slit lamp examination, there is either hemorrhage or fluid or exudation in the macular area. No other part of the retina is involved. Okay? And OCT, FFA, and ICGA, they confirm our findings. So the diagnosis is wet age-related macular degeneration. Important investigations which we have to remember in this case is that indocyanine beam angiography. It is used to visualize the choroidal vessels. It better visualizes the choroidal vessels. And this is an important takeaway point. Now, अब यहाँ पे हमने sudden loss of vision में एक और चीज ऐड कर दी, PET ARMD. You have to remember some of these things. ये आपने याद रखनी है. We will add to these list आगे जब हम बाकी details करेंगे. Now, if I were to say that our patient, this is our second case now. Our patient presents with gradual loss of vision instead of rapid. And this gradual loss of vision is not in her right eye, in both eyes. फिर आपके differentials की list में क्या क्या आएगा? This was our list for sudden rapid loss. Yes, diabetic retinopathy. हमारी differentials की list में आ जाएगा diabetic retinopathy. DR, HR और
chronic glaucoma.
glaucoma. Which glaucoma? Open angle glaucoma.
Open angle.
Okay. Gradual loss both eyes. Or
Cataract.
cataract is usually unilateral. So हम लिख लेते हैं because it's important. Cataract is unilateral loss. It's not bilateral. So I will write unilateral.
Venous occlusion.
Occlusion again, it's unilateral. Central arterial occlusion again, it's unilateral. हमने अभी ऊपर एक disease पढ़ा है. Retinitis pigmentosa. ठीक है, हमने बात की थी कि vision loss it starts early as night blindness at 15 or 16 years of age. Yes, एक thing है, मैं आपको इसको clear कर लेता हूँ. Cataract, retinitis pigmentosa में the earliest symptom is night blindness or difficulty seeing at night. As the disease progresses, that becomes difficulty seeing at day, then it's tubular vision until there is complete tubular vision, meaning a central vision के अलावा peripheral vision is completely lost. Now this transition between night blindness and between complete tubular vision, meaning complete loss of peripheral vision, it can take a lot of time, 20 years, even 30 years in some cases. So yes, it is a late presentation in 68. Unlikely in a patient 68-year-old. Retinitis pigmentosa is unlikely if she does not have any past history or any relevant examinations. But if I were to turn down the age to 58 or even 48, then it would be a likely diagnosis. One which we will include in our differential list. Now, ऊपर include नहीं करेंगे because it is unlikely or uncommon, but yes, it will be in our differential list. 6 अभी हम
पिगमेंटोसा कभी भी मैनिफेस्ट हो सकता है?
नहीं, कभी भी नहीं. इसकी earliest manifestations in younger age हैं. Classically का मतलब ये है ना कि जो ज़्यादातर cases देखे जाते हैं उनमें ये इसकी manifestations होती हैं. तो usually इसकी manifestations नहीं है कि around 10 to 15 years of age there is night blindness and afterwards onwards there is progressive diminution of peripheral vision. Now, depending upon the case, or retinitis pigmentosa further under 5-6 types हैं. Okay, it's very extensive disease. So it can either present at 30 years with tubular vision, 50 years, 40 years. But the age is just, it becomes unlikely after 60 के retinitis pigmentosa है, especially अगर बाकी symptoms नहीं हैं. इसके ये कि progression इसी तरह है, लेकिन early symptom कब आते हैं? Usually this age है, और latest symptoms कब आते हैं? Around 40 to 50. बाकी इसके अंदर सब टाइप्स retinitis pigmentosa के उन पे भी काफी डिपेंड करते हैं. वो हमारी स्कोप से बाहर है, उनको हम डिस्कस नहीं करेंगे.
इन दोनों केसेस में कंप्लीट विजन लॉस तो नहीं होगा?
कंप्लीट विजन लॉस retinitis pigmentosa में कंप्लीट विजन लॉस नहीं होता. देयर इज सेंट्रल विजन लॉस. सेंट्रल विजन इज स्पेयर्ड, पेरिफेरल विजन लॉस होता है. ठीक है, तो इन द एंड ऑफ द डिजीज ऐसे जैसे बिल्कुल जो मैक्युलर पे पॉइंट फिक्सेट कर रहे हैं, पॉइंट व्हिच यू आर फोकसिंग ऑन, ओनली दैट पॉइंट इज विजिबल, द रेस्ट ऑफ द फील्ड इज कंप्लीटली ब्लैक.
यार बकवास में
ठीक है, तो वी विल ऐड द लास्ट डिफरेंशियल अभी हम जब इसको डिस्कस करेंगे। तो मैनेजमेंट मोर और लेस सेम ही होगी। विजुअल एक्टिविटी आप करेंगे, चलो विजुअल एक्टिविटी इज सम बट बेटर इन आवर केस। 6/13 राइट आई and 6/13 left eye bilateral. Perimetry shows central vision loss in slit lamp examination, OCT. Anterior chamber examination is unremarkable. Our posterior chamber examination shows this. What do we see? What are the important positives in this case?
Yellow spots
Yellow spots. Where are these yellow spots focused around?
around macula.
Around the macula and on the macula.
At the fovea.
At the fovea, and okay, around the fovea. So we have these yellow spots around. Okay, one finding yellow spots. Second, location of these spots at the macula, around the fovea, और उसी के एरिया ज़्यादातर, ठीक है। और क्या है? और क्या है?
Optic disc के around
के
भी है.
पास
Optic disc के around. Are these same things? Look at this discoloration जो आप कह रहे हैं थोड़ी बहुत है. Are these at the same?
not the same thing.
Not the same things, right? You can see that these spots, they're circular, well demarcated. This can be something different. Okay, कुछ भी हो सकता है. These can be some hard exudates. हो सकता है. कुछ भी हो सकता है. तो yes, something wrong over here. और क्या है? What are the important negatives? Why negatives पे हम क्यों focus कर रहे हैं इस वक्त? Because we have these 1, 2, 3, 4, 5 differentials, right? Which we have to exclude. जो आपने ने मुझे बताए थे. तो when we did slit lamp examination, हमें cataract नजर नहीं आया. हमें कोनियोस्कोपी करते हैं, हमें ग्लाकोमा नजर नहीं आया. अच्छा, मेरा शायद इंटरनेट दरमियान में खराब हो गया था. आपको आवाज आ रही है सारों को मेरी?
जी.
ठीक है. अच्छा, तो मैं कह रहा था कि हमने नेगेटिव्स अब रूल आउट करने हैं. इंपॉर्टेंट नेगेटिव्स कौन कौन से हैं इसमें, एंड व्हाई दीज आर इंपॉर्टेंट? बिकॉज दे हेल्प अस narrow down our differential diagnoses. So when we say our anterior chamber examination is normal, we say that there is no glaucoma का चलो हम बाद में कर लेंगे, differential का कर लेंगे. There is no cataract. Okay? And the chamber, anterior chamber is also open. The angle of the anterior chamber is open. So what are the important negatives in this examination?
No hemorrhages.
No hemorrhages. That is good. We do not see any hemorrhages. One line for no hemorrhages. और क्या कह रही हैं?
No cotton wool spot.
No cotton wool spots. That is good. We do not see any cotton wool spots along with the vessels. और क्या absent है?
No papillary.
No papillary, ma'am. बिल्कुल. The disc margins are visible. इस तरफ थोड़े से खराब हैं. I don't know why this can be an issue, but because the vessels are entering normally inside the optic disc, we can say that there is no papillary. So there is an absence of papillary, ma'am. और क्या है?
No tortuous vessels.
No tortuous vessels. The vessels are normal. They are of normal caliber. We can see the veins are normal. And we can see that the AV crossing is also normal. Any important differential, specifically because the macula is involved, any important differential which you might want to add to this list? Diabetic maculopathy.
Macular edema.
diabetic maculopathy. That is the important thing. Okay, macula is specifically involved. Macular degeneration, बिल्कुल, it will be in our diagnosis list. ऐसे ही है. But when we are discussing all, an important thing is we have to keep in mind clinically significant macular edema in context of diabetic maculopathy. Now, we discussed clinically significant macular edema in detail. We know the different types of clinically significant macular edema. So, what are the important negatives which are missing? Which will say, अच्छा यार, ये चीजें नहीं मिल रही हमें, तो it's unlikely that this is macular edema. ये कुछ और है. What are those important negatives? ठीक है, कुछ तो आपने बता दी. No dot hemorrhages और as such नजर नहीं आ रहे. There are no hard exudates जो हमें नजर नहीं आ रहे. So it's unlikely कि इसमें diabetic retinopathy. और हमें क्या ज़हन में
No focal or diffuse edema around the macula.
Around the macula. ठीक है, the foveal reflex is intact. So no focal or diffuse edema. What are these yellow spots? These roundish yellow spots. Why are these not hard exudates? Let's focus on the second question first. Why are these not hard exudates? ये hard exudates क्यों नहीं है?
Vessels तो normal है.
Vessels भी normal है, ठीक है. और that is one thing, that's a very good thing that we will use to differentiate. Vessels are normal. We know that vessel leakage causes. लेकिन हम capillaries तो हम देख नहीं सकते properly. Leakage तो मेरी capillary से हो रहा है. तो on mobility, ठीक है, इस पिक्चर में हम मोबिलिटी भी नहीं चेक कर सकते. क्या हम देख सकते हैं इस? बिल्कुल, margins are well defined margins, one important thing. और क्या है?
Macula पे है. Specifically macula के पास है.
ठीक है, that is good. Specifically macula पे हैं, बहुत ज़्यादा macula पे हैं, और कहीं और हमें नजर नहीं आ रहे. तो two things हमें अब डिस्कस कर दी. Well-defined margins, located specifically around the macula. और क्या है? And it's right in front of you. Comment on this. Shape. The shape. Okay, they are circular or round, and the shape is uniform. There's a consistency in shape. Okay, circular, well-rounded, uniform in size as well, more or less well demarcated, located around the macula. An important point which I want to थोड़ी सी resolution blurry हो जाएगी. But do you think that this spot is in front of the vessel or behind the vessel?
Behind.
Behind the vessel, right? Similarly, this spot over here. Is it in front of the vessel or behind of the vessel?
Behind.
This spot over here, is it on front of the vessel or behind the vessel? ये वाला?
Behind the vessel.
Okay. So we saw that these are, हमें examination पे अभी तक इतना पता लगा कि these are roundish, circular, yellowish spots, more or less uniform in size, situated behind the vessels, located around the retina, located around the macula, not present elsewhere. These spots, what are they called? The first question. मैं दूसरा तो आंसर कह दिया ना कि क्या है, क्यों है, किस तरह है. What are these spots called?
Drusen.
These are drusens. Very important. This is an important buzzword. Drusens. These are drusens around the macula. Around or at the macula. और कोई इन्वेस्टिगेशन आप करना चाहेंगे?
FFA और OCT?
OCT, ठीक है, OCT आपने कर ली. अब OCT में you do not see any fluid as such. No fluid or exudate at the RPE or at the macula. At the RPE, between the RPE and the pigment epithelium, or beneath the pigment epithelium or in the choroid vessels. There is no fluid or exudate. Any other investigation which you have to do, which you would want to do?
FFA?
FFA. Why is FFA important in making sure that our diagnosis, not any other diagnosis? क्यों जरूरत है? क्या differentials हम rule out करना चाहते हैं specifically FFA? कौन सा डिफरेंशियल है जो हमें इंपॉर्टेंट है, हमें रूल आउट करना पड़ेगा? कि हम अच्छी तरह रूल आउट कर सकते हैं उसको. उसका डायग्नोसिस, उसकी डायग्नोसिस और क्लासिफिकेशन ही हमने एफएफए पे की थी.
डायबिटिक मैक्यूलोपैथी.
डायबिटिक
CRVO,
मैक्यूलोपैथी, ठीक है. No, not CRVOC. उनकी हमने डायग्नोसिस, yes we did our diagnosis, but we did not classify them based on the FFA. FFA के ऊपर क्लासिफिकेशन होती है. क्या कह रही हैं आप? दोबारा बोलें.
उनमें वैसे भी ग्रेजुअल लॉस नहीं होगा.
Gradual loss नहीं होगा, sudden loss होगा. Secondly, that is मतलब investigations to aid our or confirm our diagnosis. Clinically significant macular edema, diabetic maculopathy की classification हमने FFA की basis पे की थी. Remember, there is focal exudative, there is diffuse exudative, and there is ischemic maculopathy. That we all saw that on our fundus fluorescein angiography. So CSME is ruled out in this case. Why am I stressing on this point? Fundus fluorescein angiography is important because we did our CSME की पूरी classification, उसकी 3 types हमने base की थी fundus fluorescein angiography पे हमें जो नजर आ रहा था. In clinically significant macular edema में hard exudates होते हैं macula पर, and there is also gradual loss of vision. So if you want to differentiate between the two, number one thing is that there will be characteristic findings of macular diabetic disease in that type. इस time में नहीं है. Secondly, if CSME की findings FFA में हमें मिलनी चाहिए थी, which are not present in this case. So we have ruled out clinically significant macular edema. Last is specifically और क्या हमें एक और इन्वेस्टिगेशन आप करवाना चाहेंगे इस पेशेंट में? आईसीजी आप भी करवा दी, ठीक है. आईसीजी है, हमें जो ऊपर हमने बात की है कंफर्म कर लेते हैं. देयर इज नो सीएनवी और फ्लूइड एक्सुडेट. कोई और इन्वेस्टिगेशन आप करवाना चाहेंगे? एक डिफरेंट मतलब in practical terms में बात करें, clinical terms में, तो these are I think more or less to form our diagnosis. Since we are also considering our differentials, we will have मतलब सारी हम investigation test कर देते हैं. There is one more investigation considering gonioscopy. Gonioscopy क्यों कराते हैं? एंगल क्लोजर ग्लाकोमा. एंगल क्लोजर ग्लाकोमा की क्या हिस्ट्री होती है?
ठीक है. सडन लॉस, ठीक है.
सडन लॉस एंड यूनिलैटरल लॉस. और कोई हम करवाना चाहेंगे स्पेसिफिक इन्वेस्टिगेशन?
डी स्कैन. हमें सब कुछ नजर आ रहा है पीछे से, हम ओसीटी कर रहे हैं. If we can do an OCT, which means that there is no physical obstruction. Slit lamp पे भी we saw no physical obstruction. So what another investigation? Consider these differential diagnoses. In differential diagnosis की list को एक बार देखें जरा. डिफरेंशियल डायग्नोसिस की लिस्ट को देखें और फिर मुझे बताएं, इज देयर एनी अदर इन्वेस्टिगेशन वी शुड डू? इसको देखें। हेपेटिक रेटिनोपैथी के लिए हमने क्या क्या करना था? क्या हमने ठीक है
OCT
ओसीटी एफएफए एचआर अच्छा मैं आई एम सॉरी मैंने अभी देखा है, आई हैव रिटन डाउन पेरीमेट्री ऑलरेडी। मैं पेरीमेट्री के ही निकालना चाह रहा था। पेरीमेट्री लिखा हुआ है, ठीक है। तो पेरीमेट्री इज इंपॉर्टेंट व्हाई? बिकॉज ओपन एंगल ग्लाउकोमा the different manifestations of open angle glaucoma we will find those in perimetry. मैं perimetry बुलवाना चाह रहा था, फिर मैंने उसको देखा, I've already written down perimetry. अच्छा, तो based on these signs, these symptoms and these investigations, what will be your diagnosis?
ARM.
क्या diagnosis है आपका?
Dry age-related method.
Dry ARMD. Why is it dry ARMD?
Because
There is no hemorrhage, exudates.
And one thing, no fluids or exudates on our examinations, investigations, so also our examinations. One thing, it is dry because there is no fluid. What else? और क्या differentiate करेगा इससे wet ARMD से?
Drusen's.
Drusen's. There are no drusen's in wet ARMD. Usually in wet ARMD, there are no drusen's. Drusen's are found in dry age-related macular degeneration. और
इसमें gradual loss है, उसमें sudden है.
gradual
इसमें bilateral है.
gradual bilateral loss. This is our patient of dry age-related macular degeneration. The patient, an elderly patient, usually greater than 65 years of age, who will present to you with gradual loss of vision in both her eyes. Her visual acuity will be bilaterally decreased. She will report a central loss of vision, indicating that the macula has been affected. On set-up examination, you will see drusen's at or around the macula with absence of fluid and other signs of macular diseases. The same will be confirmed by OCT and FFA. Your diagnosis will be dry ARMD. 1 minute left. Treatment आप लोग खुद पढ़ लेना इसकी, because there is nothing less much in it. Look at this dry ARMD. Okay. Dry ARMD is also called atrophic ARMD, and wet ARMD is also called neovascular. Look at these brucins. This is atrophy at the macula. This is pigment clumping. This is next level finding है, थोड़ी ऊपर की बात है, इसको छोड़ देते हैं. On OCT we see that there is atrophy, there is no fluid, no hemorrhage, no exudation. तो हमें यहाँ पे नजर आ रही है. This is dry and wet. These are